Thank you. Thank you, Chekitan, for having me here in this wonderful instruction course. So I'll be talking on JAK inhibitors. So just continuing the discussion, I think I was enjoying the discussion. Excellent talk by Amitav Kumar sir. So I think two important things for the azathioprine is that it's not a drug if you want to prescribe a immunosuppressive in your private practice and want to sleep peacefully at night. Because if you are in private practice and you want to use azathioprine, it's always better to do a TPMT. We have come across some severe complications of azathioprine like alopecia totalis, where the patient typically complains of the hair comes up like a wig. The entire hair will come and the patient will call you, it happened within 20 to 24 hours. So there will be total baldness within 24 hours or less than that. So that indicates if your patient is telling you that I have my all hairs are coming out, tell the patient that immediately you consult a internist, because it indicates severe bone marrow suppression and the pancytopenia. So I think this is a very important when you are doing azathioprine. And a second thing is that it can happen to anyone, the LFT plus this thing. Only good thing about the azathioprine is that it is safe in pregnancy. So now all the rheumatologists and everyone have started believing, and we have a lot of data to show that the azathioprine can be used safely in pregnancy. So I'll just move to from azathioprine, we'll go to directly to the JAK inhibitors. I think it's a little higher immunosuppressive. I don't have any financial interest. Now coming to, if you see that how we work, we are specialists, we try to actually suppress our immune system. And when we try to do that, we have corticosteroid, we have immunosuppressive, and we have biological, which also includes JAK inhibitor. Now what happens with corticosteroid, when we use corticosteroid, the aim of the corticosteroid will be to move the lymphocytes from the extravascular space to the intravascular space, so that there is total immunosuppression. And as we know, the corticosteroids has a lot of systemic potential side effect. Then we have immunosuppressive, where each immunosuppressive is actually determined to destroy the inflammatory cells. Like sometimes we interfere with their metabolism. We call them anti-metabolite like methotrexate, mycophenolate and all. And that's how we kill those T lymphocyte cells, so that there is immune suppression. Now we have cytotoxic agents where the drugs like cyclophosphamide are actually made to actually kill the inflammatory cells, the macrophages and all. And that's how they affect our other body cells also. So there will be a severe immunosuppressions. The third generation, the biological, are much higher order. So what they try to do, they actually tend to block the pathways of the cytokine mechanism. For example, you have TNF alpha, which is a very potent cytokine. So these drugs are only to act on that pathway. So that's how actually it starts. Now, how the blocking JAK-STAT pathway helps. I am not going into the JAK-STAT pathway detail, but you have to understand that the maximum inflammatory cytokine, mostly the interleukin 2 and 6, they actually known to utilize this JAK signaling pathway. So the aim of the therapy is to prevent those JAK-STAT pathways, so that we can suppress the interleukin 2 and interleukin 6. So what happens here, the cytokine binds to the specific receptor on the cell surface, and following that there will be activation of the receptor associated Janus kinase. So that's why we try to use this drug to prevent that pathway, so that there is a immunosuppression. Now, there are a lot of immunosuppressions are available in India. JAK inhibitors are available in India. Tofacitinib and baricitinib is also there. But baricitinib and other drugs we are not using because they are very expensive. So the entire discussion will be actually based on the tofacitinib, which is now FDA approved for the rheumatoid arthritis and psoriatic arthritis, ankylosing spondylitis. Remember, tofacitinib has not been yet actually FDA approved for the ocular use. Now, our experience started when we used the first JAK inhibitor, the tofacitinib, in a case of recalcitrant scleritis with JV sir. And that was the first case report from India. Then following that, we published a lot of articles, tofacitinib in Vogt. Then we have a series of original articles on refractory cases of uveitis, scleritis, and tofacitinib in scleritis we have published. And recently, just now, it is accepted for publication. We have actually written an extensive review on JAK-STAT inhibitors in infectious, non-infectious uveitis, which will be coming in next edition of IGO. Now, what are the advantages of tofacitinib and why tofacitinib can be used? Number one, tofacitinib is a small molecule, more likely to cross blood-retinal barrier. This is more theoretical. But if you use this drug in like exudative retinal detachment or in any posterior segment, non-infectious uveitis, there are chances that this drug actually can act better because of its smaller size. Now, it has an added advantage over the TNF inhibitors because you can give it as a tablet. So, all the TNF inhibitors, you have to inject them in subcutaneous route, whereas the tofacitinib, you can use in oral route. And also, if you look at the dermatology in other subspecialty, they have started using this JAK inhibitors in a topical form. So, the days are not far when the tofacitinib and other things can be available in topical forms also. Now, tofacitinib, another characteristic is it has a very rapid absorption and elimination. So, peak concentration reaches 0.5 to 1 hour and it has a half-life of 3 hours. So, it stays less in the body and acts really fast. So, these are the advantages of tofacitinib. Now, let's come to the second point I want to highlight, the cost of the treatment of tofacitinib. Now, a 9-year-old boy with chronic anterior uveitis diagnosed with juvenile idiopathic arthritis, and there is significant joint involvement. Now, the patient was sent to pediatric rheumatologist. The first choice of the drug here is that adalimumab with methotrexate. Now, if you see, even with the biosimilar, the cost of per injection with adalimumab is 6,000 to 12,000. So, this is sometimes not possible for normal Indian patients who does not have any insurance cover. So, in that scenario, the tofacitinib and methotrexate can be a game changer. Why? If you look at the cost of the therapy, the adalimumab, the lowest, if you are purchasing directly from the company, then it comes around 6,000, but in MRP rates are always higher, like 12,000 and more. But here you see the tofacitinib is per tablet cost around 20 rupees. So, per month therapy is 1,200. So, that's why I keep telling all that it's a poor man's biological. You can actually use that. Number 3 point is that role in treatment resistant cases. This drug actually can really work well if you use in some certain cases. Like this is a case of 13-year-old boy, recurrent posterior scleritis who did not respond to oral steroid and methotrexate. Then we shifted to both methotrexate and mycophenolate. Still he had recurrence. And finally, the tofacitinib with tofacitinib we can achieve the remission. Now, this is another, you see that a 50-year-old nodular scleritis, the steroid, mycophenolate and methotrexate was not effective. And finally, the tofacitinib actually helped to attain the remission. Similarly, this another patient, 40-year-old male, diffuse anterior scleritis, steroid and azathioprine was started, and there was a severe rise in the liver enzymes. So finally, we shifted the patient to tofacitinib, and it really worked well. I'll show you another case, a 50-year-old male with diminution of vision. You can see he attended another hospital because of the sympathetic ophthalmia, where they treated and told that it cannot be done because it's almost lost guarded visual prognosis. This patient came to us with complicated cataract, and you can see the slit lamp photograph. And this was the, you can see the bullous RD, you can see the configuration well in ultrasound also. And this patient we treated with IVMP, oral corticosteroid and tofacitinib, and it responded really well. We actually further went ahead and did the phacoemulsification with IOL implantation, and you see the response here from counting finger it actually increased to 6/12. So now if you see that what are the cautions you have to take, that you have to understand that this drug can be used with caution in elderly individuals. There are chances of venous thrombosis and the cardiovascular risk, because this drug can actually affect the system. This is another case report we published, though we don't want to contribute, but we thought that we must tell the world that this can happen in elderly patient. This patient was a known patient of hypertension and rheumatoid arthritis and non-necrotizing scleritis not responding to steroid. We used tofacitinib, and after I think 2 months later, the patient developed superiotemporal VRVO. Now you can argue that it can be due to the primary existing hypertension and other risk factor also, but we decided that at least because thromboembolic side effects are common with tofacitinib, so we must publish this case report so that we can tell that there may be chances of that which you should not overlook. So the drug should be used with caution in elderly. Now, just last point I'll highlight that the risk of infection is very common. This is a 41-year-old lady and developed herpetic stromal keratitis at the periphery after the use of tofacitinib. So the viral infection is known to be a very common factor or common risk for use with the tofacitinib. And here you see there is a wonderful lady who presented with scleritis, and there was a history of tuberculosis related cervical lymphadenopathy. Tofacitinib was used for 5 months, but there was no recurrence or reactivation of tuberculosis. It has been claimed that the tofacitinib, the risk of TB, which is much higher with the TNF alpha blocker, is less with tofacitinib. So this can be a very good point in country like India to use this drug. Now, but you have to understand, I told you the viral infection is common and you have to tell your patients for that. This is another patient who developed herpes labialis after 1 month of tofacitinib use. But you have to understand that these viral infections are very mild in nature. This patient, the tofacitinib was stopped and she was started on oral valacyclovir. In view of persistent scleritis, we continued the tofacitinib. That's all. Thank you.
Thank you, Dr. Partho, sir.
I just wanted to ask you that have you used the tofacitinib in some conditions like vision-threatening uveitis like Behçet's disease, serpiginous choroiditis?
Serpiginous, if it is autoimmune, I think one can use. Behçet disease, I'll be little reluctant because we should treat the Behçet disease very aggressively. And Behçet disease, I think it's better to, if the patient can afford, I'll just prefer to treat them with biological.
Also, Dr. Partho, can you please elaborate on how you, what are the investigations that you would do before you start tofacitinib, which you add? What are the investigations which you would like to keep on doing? You know, like for azathioprine, methotrexate, there's a fixed timing. You know, you do it in 2 months or 1 month.
Yeah.
And what would be the starting dose of tofacitinib? How long can you continue and how do you taper? And what would be the main indications in short?
It's a very good question. So tofacitinib, if you read the literature of all side effects or the effect, no, it has been typically associated tofacitinib used 10 mg twice a day. But tofacitinib in our setting, we use it as a 5 mg twice a day. So the side effects are much less. Unlike biological where we need to do MON2 and other tests before starting, tofacitinib actually does not require any pre-test to start the drug. Only one thing I feel in any pharmacotherapy, if you are doing, always try to do a baseline liver function test, because any drug can cause rise of liver enzymes, and you need to have a baseline comparison to show that whether the effect is due to drug or due to some other things. So I think LFT you must do, routine blood count you do, though it does not have any implication with tofacitinib. Coming to azathioprine and methotrexate, I always try to do the baseline investigation like blood count and liver function test. It's also important to check for this hepatitis B and C markers. These are very important, which we often overlook. I think it's always better to do this marker before you start the immunosuppressant.
I've got a last question. So I want to ask you, like a HLA-B27 positive anti-uveitis having multiple recurrences, can you give, to prevent recurrences, we give methotrexate, can you give tofacitinib?
I won't prefer, sir. HLA-B27 associated uveitis with recurrent attack, I'll try to treat with oral methotrexate, because that will be my common drug. Tofacitinib I will use only if it is not responding to other drug. It's never a first line drug to be used. I think we should not treat all patients with tofacitinib. It should be reserved for certain cases where it's not working to other medications.
Yeah, what would be your main indications in a short?
Tofacitinib, as I showed, I will use if it is not responding to one immunosuppressive or two immunosuppressive. It's sometimes the biologicals are indicated, but the patient can't actually afford biological therapy. These are the cases I think we can try tofacitinib.
How's been your experience in intermediate uveitis or pars planitis? Have you ever used in that?
It's good actually. It's a good drug. It can means help you to achieve a good remission of the drug. But yeah, in acute cases, severe cases, I think as I always prefer that you have to use the corticosteroid to
Like
bring down the
suppose
inflammation.
we are giving oral steroids, can we start tofacitinib, or should we give oral steroid
can.
methotrexate and then go to that? I mean, how should we go?
Yeah, usually that's the standard. Like
Right.
you use methotrexate and then
As
you
a
go
third,
to.
this thing.
Yeah, I have a question. Excellent talk, Partho and Amitabh's talk. Now you see why tofacitinib is used in ulcerative colitis. That's a very because no tofacitinib is given orally, and you see ulcerative colitis which involves the gut. Do tofacitinib had effect on the microbiome? Okay, there are protective and beneficial microbiome. There are what you call harmful microbiomes. Okay. Now, if the harmful microbiome get killed, does not matter. But if the protective microbiome get killed, then it is a problem. And now you are telling that it can come as a ocular drops. Okay. Now, what is the effect of those tofacitinibs for the local as well as GIT microbiome?
I think the treatment in ulcerative colitis is totally different. It does not have any oral or anything, because main thing is to prevent the inflammation of that particular GI tract area, and that is inflammation based. I can tell you about the immunosuppressive effect of any drug, but I am not the right person to ask about the gut microbiome. I'm sure that many of us, we are just learning to understand that about the gut microbiome. So I have no idea about how tofacitinib is actually affecting the gut microbiome here. I don't have data also to discuss that. Regarding the ocular topical use of tofacitinib, because if you look at the our dermatology colleague, they are the first have started the JAK inhibitor as a topical form. They have all kinds of hair lotion and everything of tofacitinib, and there are actually many ophthalmological companies are actually investing now to bring this to various JAK inhibitor in topical form to treat the anterior segment inflammation. Few rabbit model studies have shown that the topical application of JAK-STAT inhibitor penetrates much more into the posterior segment than the corticosteroid. So we are hopeful that something may come. These are my assumption based on the existing literature, but that's it.
Sir, I have two
Yeah.
questions.
Yes, madam.
That was a very nice talk, sir. It was
Yeah.
an eye-opener for us. Sir, once we have start corticosteroids, then corticosteroid with methotrexate, how long we wait for each medicine to assume that it has failed and then go for the next medicine? Like
Yeah.
I have a patient with scleritis. I'm not a uveitic person. With the long-standing anterior scleritis, not responding, now she has got a nice scleral thinning. It shows as though she's going to go into staphyloма formation. And now we started her on methotrexate. How long should we wait for it to, because she's again and again still having attacks?
Thank you, ma'am. It's, I think, very important question. I'll try to answer your question in two parts. The number one, you asked that how long we should wait to understand the efficacy of a drug. That will be with a drug like methotrexate and mycophenolate. These drugs actually takes a lot of time to achieve the desired level of serum concentration. So methotrexate and mycophenolate, it's ideal. It takes actually almost 1.5 months to achieve the desired level concentration. So if you want to tell some patient as a treatment failure with this immunosuppressive, I think it's better to wait at least 3 months. 3 months of therapy, then you can actually decide of changing your immunosuppression. Coming to the part 2 question, you told that you are dealing with a scleritis patient which is having a scleral thinning and staphyloma formation. I often feel that often in ophthalmology we are taught that you go in a phase manner. Like you first try this, then this, and then you go to the final step. Like biologicals, many of the time we are afraid that you should not be used first line therapy. Even I believe in that. But conditions where the ocular integrity is in threat, for example, a patient of necrotizing scleritis showing thinning, this is not the ideal case experimenting and going phase-wise manner. These are the conditions you have to directly go for the aggressive therapy. So these are the conditions I will recommend you directly you send the patient to rheumatologist, evaluate and start some biologic. Because you can't wait for why the methotrexate or mycophenolate is waiting or not. Because 3 month time for a necrotizing scleritis with scleral thinning and staphyloma formation can be dangerous.
So you're treating yourself, sir, or you're sending all the patients to rheumatologists?
Biological, yes, we are sending. That's what my the main aim was, that we are sending for all the patients to rheumatologists for the biological therapy. The JAK-STAT inhibitor, because it is available orally, maybe a time will come when the ophthalmology will start prescribing the drug, just like we prescribe
Thank you.
methotrexate and
Thank you, sir.
mycophenolate.
Thank you.
Partho, you can't leave so early. Just last question.
Yeah.
Do you take any special precaution as far as the antibiotic prophylaxis is concerned if a patient is on tofacitinib and is undergoing a cataract surgery?
I don't take.
Nothing.
Don't take.
Okay.
Thank you so much, Partho. Lot of